Any comments from you folks on things that you've heard this afternoon? All right, well.
Oh, always happy to jump in. Love the presentations. Oh, is there another mic running here? Love the presentations and regarding the ease that small businesses have an ability to enter in the dietary supplement industry. It offers unique challenges and a unique opportunity for us to offer training and mentorship to these new folks so they can be responsible manufacturers and serve the public in an honorable fashion. So always good to get more information about where people are starting out. So thank you.
At the back.
Hi, so Mark Anderson mentioned in his talk that red yeast rice at one time was taken off of the market because it contains lovastatin, and I guess the FDA determined that it was too much of a drug or drug-like in its efficacy, and that's part of the reason it did that. And it reminded me earlier in the day that Christine Taylor brought up in her talk the Relax Pro seizure of that Kratom product that they had. And it just sort of made me think that, well, maybe kind of what we're seeing here is there are different categories of the way in which the FDA works top down to regulate. And so some are obviously in the public interest and some are maybe more ambivalent. And I was wondering, you know, regardless, because obviously there are some problems with like red yeast rice or any of these products that, you know, need to be smoothed out, and you know, quality control is important no matter what. But I was just wondering if maybe you could speak to how the audience here and just the general public might work with your organizations and generally speaking to sort of you know, be in touch through you guys with the FDA and other sorts of regulatory bodies that are broader than yours in terms of maybe suggesting that regulation should come from the bottom up as well. And yeah, if you have any thoughts on that.
Just wanted to mention something about the red yeast rice incident. And that was, it was kind of unique in that I believe lovastatin was out there and patented already. So it was already a drug. And the person that had this red yeast that found the lovastatin was bound and determined to find out why that product lowered cholesterol. And when he really delved into why the compounds that were in there, lo and behold, he found lovastatin. So the FDA had the right to go in there and take it down because it was a drug at the time.
But it contains other components.
So yeah, but they're all it is a complex mixture. You're correct, but it does contain a drug. So you can't. It's a supplement.
Another instance of human ingenuity needs to trump any sort of natural sourcing, which is why increasingly regulation has said that for people who are doing natural products drug discovery, that you need to involve synthetic and medicinal chemists with your work so that you can modify whatever you find from nature and then it no longer belongs to you.
Well, it's interesting you mentioned that because just at lunch we were talking about something similar, and that is that when you guys do your research, everybody wants to get the companies want an outcome of your research. Well, what did it do? Well, it increased bone density. Well, it lowered cholesterol. And here's the outcome of my study. Well, you've just done a study for a drug. Now, is it a dietary supplement or is it a drug? So those are the kind of things you guys are going to have to wrestle with.
The tactical drug category might be able to mitigate some of that. It's still expensive to run all those clinical trials, but at least that category exists in the FDA. But maybe that also can reinforce their sort of regulatory actions as with these rights.
Well, there is a way to actually patent a natural product. and you don't have to change the chemical structure of it. You have a use patent. I've got 7 of them. And what it does is you write it for the use of that particular natural product for a particular outcome. And so you identify the chemical and the chemical of that natural product. I have a couple of astaxanthin, and because my background's in pharmacology, and I was an analytical chemist throughout school to pay for my education. So I was able to do some clinical work as well. But there is a way to do that, and it can be done if you're just creative enough to do it.
Do others on the panel have thoughts about this question? Perhaps because it's red yeast rice? I do. Lovastatin is an ingredient in red yeast rice. It's also an ingredient in a drug. We've never had to deal with the issue. I mean, an ingredient can be in lots of forms. It can be in a hearing aid. I'm making that up, but it very much depends on the intended use. And where we were starting to run into problems is that a company that was making red yeast rice, tell me if I've got this right, was able to manipulate levels of what appeared to be the active ingredient. And it was the notion that you could change the active ingredient content that bumped up against the fact that there's a drug in the market that does that perfectly well. If there is a drug, you can't make a dietary supplement out of a drug. But the countervening issue is the one that ingredients can be in different places at the same time. Steve?
Well, I would just add, I think it's me. I would just add to that, I think lovastatin and red yeast rice are kind of an unusual situation because you did have the drug was already in the marketplace. And it does create kind of a dilemma for companies who want to sell red yeast rice because on the one hand, they're not allowed to manipulate or standardize the levels of lovastatin in red yeast rice. That's what got them in trouble in the first place, as you point out, Paul. So you're not allowed to do that. So if you put a product into the market that it has not been standardized to the lovastatin, you're going to get variability from lot to lot. So FDA won't let you standardize, and then if you put that out there, then when a third party comes along and tests the product, they're going to say, oh, well, you don't meet our standards because you've got widely variable levels of lovastatin. So I think it's an unusual case. I don't think we need to spend a whole lot of time on it, but it does, that particular ingredient does present a problem to the industry because of the fact that there's the provision in the law that says if the product has previously been subject to public substantial clinical investigation as a drug, it cannot then become a supplement. And in that case, you had lovastatin that was already patented as a drug, and then they discovered that was what the active was in the red yeast rice.
Yeah. As you say, it's a bit of a unicorn, but sometimes we learn things from these unusual cases.
Unfortunately, it leaves consumers in the dark because unless they read consumerlab.com's website, they won't know that there's this huge variation and that what they bought one year might not be the same the next year. And so it's really the consumer that may lose in this.
Merle?
Oh, I was just thinking there are other cases such as willow bark containing compounds like aspirin, where there's an overlap between the naturally occurring dietary substance and substance that's marketed and sold as a drug. So it's not necessarily that this one example stands completely alone. There's a context that it can fit into.
Yes, ma'am.
I have a question that kind of parallels this situation. You can get prescriptions for prenatal vitamins, prescribed by your doctor, and then you can go to your local CVS and you can buy a similar formulation. But one does not equal the other. And so recently I was talking to a friend and she said, my doctor said, oh, just go to the store and buy what's on the shelf. But one's been proven to do something, one has not. Where is our responsibility to, of supplements being used as a drug in that situation, and if it's being regulated? Is it still a supplement, or now, since it can be prescribed, is it a drug?
Go ahead. There are various products that are sold both as supplements and drugs. And so, a lot of that is the product of the insurance system and where you get co-pays and reimbursements and things like that. So I guess I would take issue where you say one has been proven and the other hasn't. I think the over-the-counter prenatal is just as effective as the prescription drug. You've also got fish oil, which has been on the market for a long time, and now you have Lavazza, that and they will claim that that's a different product, but it's still omega-3 fish oil.
I think I'm just curious because in one situation, all of the ingredient, like this conversation has been going on today, you could have bottle to bottle differences in what's actually in that over-the-counter medicine. So when a doctor says, oh, just go get this, a pregnant mother might go to the store and pick up a bottle that has a lower dose than she actually needs to be effective. Shouldn't the recommendation be take this as a recommendation from a doctor, I want you to take this because I know how much that has in it, and I know all the excipients that are in here?
But many doctors will do that. They'll prescribe either a brand, or they'll say, go look for a brand that has NSF on the label. Or many doctors now, will have their own brands of supplements that they sell through their practices.
Okay. It's just,
But the product is still, it's still the same thing.
okay.
It's still a prenatal, and I guess I do want to take a little umbrage with when I have heard a couple times supplements are not regulated. And as Paul knows, that's a whole hour-long presentation that I would be happy to give on why they are regulated.
Please do.
We have an enforcement issue, but the notion that supplements are not regulated, they most definitely are regulated. Their manufacturing is regulated. Their safety is regulated. And through the NDI provisions, there should be nothing in the market that has come into the market in the last 23 years that we don't know about its safety. And if it's not being enforced, that's a different issue. There is post-market surveillance in place with the adverse event reporting requirements that companies are required to turn those over. We have 10 years worth of data now on adverse events. So I guess I do bristle a little bit in the notion that the supplement product is not regulated and that the prescription drug is. They're regulated differently, but they're regulated.
There's a slightly different, or a different way of addressing part of the question that I wanted to probe a little more with you. The implication was that one product, call it the prescription version of prenatals, was more reliable than was the non-prescription version. Ask that question tomorrow of Johanna Dwyer when she gives her talk on use of dietary supplements, because she and others in the office, along with our colleagues at USDA, have been looking at the content of prenatals that are both prescription and non-prescription versions, and you might be a little surprised at the outcome.
If I can just weigh in on this, I'm not a regulator or a regulatory expert, but this has a long history. And one of the challenges that we have in the dietary supplement space is the breadth of it. But if you think back to the regulations, we identified nutrients that were essential for life. We also learned how to make them and mass produce them and started to fortify foods. And that was the beginning of having a nutrition facts panel that said, this is the standard by which it can be measured, and the amount that is going to be put in by law will be within a certain variance of that daily value. And you can identify whether it's 5%, 10%, whatever, but that is a labeling of an essential nutrient. That's done, and in some cases, there have become products that are prescription for specific physiologic states, pregnancy, lactation, or disease, that they're products, and they may be higher concentrations, but they are always administered under medical supervision. And that doesn't mean that they are different in quality than those that are over the counter. And the labeling is really pretty clear for those essential nutrients. Then within the dietary supplement space, we also have then beyond that bioactives and many other things that are being marketed and put. And I saw labels earlier today, and I look at it and it's like, I would never buy that. I don't have a clue what any of these things are and what the quantity in them is relevant to efficacy. Is my source going to be prevention? Maybe, but that's not the FDA. The FDA's requirement and the manufacturer's requirement is because they're the ones that are advertising and putting romance language on the product that's being monitored for whether it's truthful and not misleading. And it needs to be enforced so we don't have those other products in the marketplace.
I think there were some other questions that had arisen. A lady at the back?
I get that you have a deal with it saying it's not regulated when it's regulated, because we've learned over the last couple of days the regulation on the label and everything is regulated. But after seeing David's PowerPoint, we also saw that the regulation still leads to a product that is nothing that all the regulations state that it is. So us as healthcare providers, when we're saying a product isn't regulated, when we're trying to get it to the athlete or tactical athlete or whoever your population is you're working with, it's easier for us to say it's not regulated, because if we go through a 3-day presentation like it took for you guys to tell us that it's regulated, then we're going to lose them. So it's easier for us to say it's not regulated, make sure you have a third-party auditor, here's what you should look for, rather than being it's regulated but blah, blah, blah.
Well, I guess I would suggest you shouldn't mislead your patients and tell them it's not regulated. Maybe the better way to say is dietary supplements are regulated as a category of food, and there are certain standards in place, but the same standards are not the standards that would be used for a pharmaceutical. And it takes 30 seconds extra to do that. I think that's the more honest and complete answer to give your patients. I love David's example on green coffee because it is a real problem for the industry. But the issue there is that at every step of that process, people were violating the law. And so there was no question whether the activity is illegal under DSHEA, under the Federal Trade Commission Act, under the Fair Advertising laws. I mean, no question that's illegal behavior. The question is, how did this behavior continue and continue and continue, and none of our regulators called them on it? And the important distinction here, again, I'm an attorney. I think maybe I'm the only attorney on the panel. The important distinction here is that when we say dietary supplements are not regulated, we are encouraging a change in public policy to run to Congress and change the law. And there's nothing wrong, in my opinion, with DSHEA. DSHEA provides FDA with lots of tools. The Federal Trade Commission Act provides the FTC with lots of tools. There are plenty of things there that allow them to regulate this industry. The problem we have is that they're not using the tools that they have, whether it's an issue of resources or funding or a lack of political will to want to do it. And that's a totally different conversation, because now you're talking about putting pressure on the administrative agencies to do their jobs and putting pressure on Congress to fund the agencies so they can do it. And so from a public policy standpoint, that's very different than saying run to Congress and change the law.
So let me just make a quick comment that none of you should leave this room saying comfortably that dietary supplements are not regulated. You might want to use a simple language like dietary supplements are not regulated as drugs, period. Yes, ma'am.
I want to say that I teach physicians, and what I have found out from all my patients in 30 years, that if a physician doesn't know something, or any kind of physician, MD, DO, homeopath, and sort of BS's doesn't tell them what's up, that the patients will go find information on their own, and often that's not accurate, or they'll go on the internet. So I think it would be better for us to advocate for more credible education within all medical type schools, even if it just says, these are the warning flags, this is how you read a label, go find a dietitian, go find somebody, but don't go to a health food store. But I think when we give partial information, we do more harm than good. Okay. Thank you.
I realize that I might have cut you off. I'm sorry, I didn't intend to, but you had a follow-up question at the back?
just gonna say, so we should say it's regulated, just not enforced.
Under enforced, how about that? Why don't we find a middle ground? Under regulated but under enforced.
Got it.
I won't argue with that.
All right, we can now write the paper. Are there other questions or comments from people in the audience? Any comments from the panel members that they'd like to end with? Oh, yes, ma'am, you had a question?
Well, this is Annette Bush. I'm from FDA SIFSAN. I think we run into underreporting. That's always been an issue. I think that consumers, if we give the consumers the right surveillance tools, such as our CARES, our FAIRS, our events reporting system, that maybe we can redirect them where to report, so that way we can gain the claims or the reports from the consumers, and then we can then mitigate further.
Okay, thank you for that comment.
If I could hop in. If you want to tell your consumers to report to the company on the bottle, there'll be contact information. They're required by regulation, by law, to bring that information directly to FDA. They'll be familiar with the processes and they will report, or they'll be written up for not reporting, and it'll still get to FDA. So if that might be something you could do.
Howard?
Thanks. It's always good to hear all these different perspectives on the topic. And I think one thing that I always think about is that a lot of times if I'm interviewed by the media about some study that comes out, particularly when it relates to dietary supplements in some capacity, I feel like there's always a canned statement that I put in that's something along the lines of, before you make any decision about taking particular dietary supplements or not, to consult with your primary care provider, your dietitian, or some other healthcare provider, as you had also mentioned down below. But yet, I think that we're still missing a big opportunity in terms of education and or empowerment from the healthcare providers to try and work much more closely with the patients and trying to make decisions on whether to take particular supplements or not. And so there's a lack of empowerment, I think, not just on the consumer side, but also on the healthcare provider side. And I guess the question I had for the panel is, with appreciating each of your different perspectives on this, is rather than simply saying more education, I guess I was just more thinking, how can we better empower the healthcare system to help inform the patients about trying to make meaningful decisions about what supplements they may or may not decide to take?
Any thoughts from panel members? Steve?
I'll jump in because we've given this a lot of thought at CRN. And I think, we need to start with curriculum in medical schools. So that they are getting more about nutrition, not just supplements, but nutrition generally, and then supplements in particular, right from the beginning of their careers. We do a lot of work with nurse practitioners and pharmacists to try to do education at that level. Quite frankly, we don't have the resources to do education for doctors, because we're competing at that point with pharmaceutical companies who can fly you to Hawaii for the weekend and tell you about the latest and greatest drugs. So we find it's just really near impossible to compete in that space with doctors. But what we're finding is nurse practitioners, physician assistants spend a lot more time with the patients anyway, and that's an area where they can be a gatekeeper of information, and they can ask those questions about what are you taking, why are you taking, let's look at everything. And we always advocate people, the consumers, go to their healthcare providers and bring the bag with you if you want.
Other comments? Michael? And then David?
I'm a very big proponent of having status measurements, and that's because I work in the world of vitamins, minerals, omega-3 fatty acids. I cannot look in the mirror and determine what my nutritional status is. So I don't know whether I need to be taking 800 IUs of vitamin D or whether I need to go on 10,000 for a course until I get my serum 25-hydroxy D levels. I eat salmon 3 to 4 times a week. I had my DHA and EPA test. It was well below healthy recommendations. The only choice, so I had a choice. I can eat more salmon, or I can take a fish oil supplement with a known amount of EPA and DHA. I believe that's the only way we can move forward successfully. I think we need to encourage testing. We need to encourage the emergence of new technologies that are coming to do that. And then we need to look at the tails of those distributions and find out who is deficient or who is way too high. And that's an education opportunity at that point, or a regulatory one.
So I would counter that, Michael, with respect, that testing for people without any clinical indication is likely to be a humongous, expensive task at the public health level. It's done as part of a clinical practice, in a clinical practice setting makes sense to me. You have some trigger, some reason to be wanting to look at levels. But I don't think that this is a practice that could be sustained in any kind of healthcare cost environment.
I believe there are emerging technologies, and I will counter with the proposal that if you went back 50 years ago, people would say you would never do a home pregnancy test. And that was because it's too much of a healthcare cost. And we now have home pregnancy tests, and I believe there will be others for nutrient status.
So we have more reliability with home pregnancy testing than we ever did before. One of the concerns about public health level testing of nutrient status is that the chances of false positives are immense and lead to more testing and lead to perhaps unnecessary supplement use and maybe avoiding a more appropriate approach to dealing with what might be a clinical problem. There's always a tension in this area, and I'm not really trying to argue. Michael and I have been friends for a very long time, and we're both Canadian, in case you didn't notice that. But the point is that there are
politely
always...
disagree.
What's that?
So we will politely disagree.
We'll politely disagree, yeah. But there's always a tension, and that's the point of this. There's always a tension. Steve? Oh, I'm sorry. David, I think, had an opportunity that I wanted to give.
I wonder about the usefulness of a course in medical school. Let's say somebody took that course 15 years ago. Would that prepare them to deal with the questions today? I mean, science changes all the time. We're learning new things. We tried to get the Congress to fund a National Academy of Sciences report on the various dietary supplements, the efficacy of various dietary supplements, so that physicians and other healthcare professionals could refer to that as a source of information, but we were unsuccessful. We were unsuccessful getting industry to help support that mission.
Okay, I want to make a comment to respectfully say I think it's important that physicians get a core 47 or so or 50 hours in nutrition so they know how to look at the literature and think about it, so they know when to identify the correct triggers to refer. Because registered dietitians are underutilized, experts are underutilized. If they don't know how to refer, what happens is we get the Dr. Oz's and everybody else. And because they have an MD or a DO after their name, they can hang that up and they're the expert. And it takes years to undo what one doctor has said. That's wrong. So if they have base knowledge, just like even nursing gets one whole semester of nutrition that they can branch from, then that's a leverage. And you teach it systematically in the system. Every single system from the DNA up requires solid nutrition. So I think it's just a basic science that they should have understanding of, so they know when to refer.
Yes, bringing up about the education and nutrition in medical doctors, I do agree with you that they need more. There was a study that came out in 2006 that was published in the American Journal of Nutrition that showed that only 34 out of the 126 universities that had medical schools that taught even one class in nutrition. So you had to start there first before you have them really understand it after they graduate.
Yeah. We're running out of time, but Steve, did you have a comment that you briefly wanted to make? Okay. Are there any other comments from members of the panel? Sarah? Mark had to leave, I know. David? Steve? Merle? Okay, sure.
As Helvetius said in 1758, truth is a torch that gleams through the fog without dispelling it. I think working together, I can see all our passion towards a brighter future, towards providing consumers with the information and the knowledge they need to make good decisions, and professionals alike. And it's just a pleasure to participate in the panel. And I want to thank all of you attendees and the organizers for putting us all together so we could hang out.
Michael, did you have any final comments you'd like to make? Okay, well, so let me ask you all to give this group a great standing ovation again.